Let's now have a look at the examination of tibial bone stress injuries. These are very, very common in the run-in population. In terms of location of symptoms, the breakdown is that they infrequently occur in the proximal region of the tibia. About 4% of all tibial bone stress injuries occur there. We will more commonly see them in the middle part of the tibia and the distal part of the tibia, circa 40% for each. If you do have a patient that reports pain in this proximal tibial region, your antenna should be up because that's more likely to be a stress fracture if it is sore in that area proximally. Location-wise with the tibia, we also need to take note of whether the patient, in this case Josh, is telling us that they're getting pain anteriorly or whether they're getting pain in the more classic and common location, which is the posterior medial, so posterum medial border of the tibia. Symptom-wise, like we mentioned with the general principles of bone stress injuries, Josh would be reporting pain with activity that is scaling up as he continues to load that bone. So it's becoming more prevalent in terms of it's now starting to interfere with the running while he is running. Something that runners with tibial bone pain can often report is that they feel in the early stages like the bone almost warms up. It almost behaves like a tendon. So they feel a bit stiff with the first few steps and then it will often warm up. But as they continue to load, that develops into pain after activity and then during activity. Now, tibial bone stress injury assessment, the key thing here is the location of pain. And second to that would be palpation. Third will be the single leg hop test. So let's have a look at palpating the tibia for tibial bone stress injuries. Josh, can I get you to kindly have a lay on your back, face up to the ceiling there, please? So we'll always palpate the asymptomatic leg first. In this case, we'll jump straight to Josh's symptomatic side here. This is a mock example. Josh doesn't have shin pain, but I'll start at the front of the shin. Josh, important to tell me if you feel soreness, pain as I do this. If you feel uncomfortable any time, you let me know and I'll stop. But I'll just work up the tibial anterior cortex there, thumb width by thumb width, taking note of any regions of soreness. Now, remember the anterior tibial cortex is not an area that we are wanting to pick up symptoms in because it is notorious for slow healing and poor outcomes. Now, we'll go from the anterior cortex to the medial malleolus. You can get medial malleolar bone stress injuries. They are not common, but it's important to have a feel around that anteriorly, the middle, the posterior margin, before you start to then palpate up the posterum medial border of the tibia. So you're working from distal to proximal, trying to keep some firm pressure on there the whole time, monitoring the patient's face, asking the patient if they're experiencing symptoms, and then also marking on the skin where symptoms start and end. So let's say I've gone all the way up to Josh's proximal part of his tibial plateau up here. I'll then go back again, or if I captured this initially, and say, all right, Josh says he's sore there. So I'll get my marker out. Josh, you okay if I draw on your skin there? Indicate where the soreness starts. Josh is still feeling pain, but it stops just north of my thumb there, or proximal to my thumb. So in this example, mock example, Josh is telling us that he's got pain from here to here. Now, if we measure that distance, we're looking at 3 centimetres. So a length of the tibia, 3 centimetres long, that is sore. This is important because we know that if this soreness region is less than 5 centimetres, it is more likely that Josh, in this case, is experiencing pain due to a tibial bone stress injury. Now, if in contrast to that, Josh's region of soreness is greater than 10 centimetres, then we can very confidently assume that this medial soreness is not a tibial bone stress injury, but rather periosteitis, which is also known as medial tibial stress syndrome. So the distinction needs to be made of tibial bone stress, less than 5 centimetres. Some say less than 10 centimetres. The work of Milgram et al., 2021, they looked at Israeli military recruits, and they believe that the region was 10 centimetres, where you could really clinically infer that less than 10, probably bone stress, greater than 10, medial tibial stress syndrome. Medial tibial stress syndrome, the synonym for that is periosteitis, which, as you recall from the Fredrickson classification image that we looked at, is where the handkerchief or the wet tissue, the tissue that wraps around the tibia like a wet handkerchief becomes inflamed. And that runner, in this case Josh, could keep running. And we'll talk about that through the management, how to keep the MTSS patient running. But the runner with tibial bone stress less than 10, or to really take it home, less than 5 centimetres in terms of length of soreness along that tibial border, they need to stop. And we'll talk about that in the management strategies for tibial bone stress injuries. Now, we're talking about the objective examination for these injuries. We've taken note on how Josh walked into the clinic. He seems to be walking okay. We have palpated the area. We are now going to look at some load tests. So jumping on up off the side of the table here, please, Josh. The single leg hop test is a wonderful test for tibial bone stress injuries. It has a sensitivity of 100%. So remember, sensitivity means there can be no false negatives. Or in other words, if I got Josh today as my patient to hop on his symptomatic leg and he does not incur pain, then we can rule out that he does not have a tibial bone stress injury. The specificity of the single leg hop test is much lower. It's 45%. So if Josh does test positive for a single leg hop test for pain, we would probably be absolutely thinking that this could be bone stress injury, a bone stress injury to the tibia, but we still then need to work through our clinical reasoning through the subjective, the onset of pain, the mechanism of injury, to look at other differential diagnoses for this area, which can be quite numerous. It can be a calf muscle strain of the soleus or the gastrocnemius. We could be looking at popliteal artery entrapment syndrome. We could be looking at chronic exertional compartment syndrome. We could be looking at plantaris conditions or neurological conditions. So there's still a bit to work through diagnostically, but we've ruled those out in this mock example, and we are looking at Josh as a likely bone stress patient. So Josh, can I get you to stay facing the camera, but can I get you to, or facing forwards, do a single leg hop on your unaffected leg there, the right leg? Yep, just sub-maximally, just going up and down 3 or 4 or 5 times. Yep. Now let's do that on your affected leg. Now, if you want to use the wall or some support to start with, off we go. Any soreness there, Josh? Now, Josh is going to point to where he's feeling sore, and we're going to quantify that with a VAS scale for pain. So, Josh, out of 10, what level of soreness? And pick a number, 0 to 10. 7, all right. So if Josh is reporting a 7, we are not going 7 out of 10 for pain. We are not going to then go and index Josh to go higher with demands at the risk of not knowing where this bone sits on the bone stress continuum. You can go from okay to not okay quite quickly with bone. So you make a clinical call at that point to go, right, well, 7 out of 10, that's quite a high reported pain. We are not going to get Josh to do a drop jump or a forwards hop necessarily to index it up further. If the pain score was lower, you may do that just to look at some of the behaviours and to also further rule out something like a calf muscle strain injury, for example.